Hello, I'm Marcy Setlow, and I'm publisher of the online newspaper, the Berkshire Edge. I want to welcome you to our webinar, which is, in a way, a continuation of a housing webinar that we produced a year ago. In that webinar, we assembled a number of housing experts to talk about ways in which local and state programs are addressing the housing crisis in the Berkshires. But today we're doing something a little different. We do have a few housing experts with us, but primarily we have assembled a group of healthcare professionals. And they are going to talk about how they are experiencing the housing crisis in the Berkshires as a medical crisis. Their inability to staff their offices, the effect that poor housing has on their patients, the difficulty of recruiting new doctors and dentists to come to the Berkshires. So this webinar really reflects the deep interest that the Berkshire Edge has in delving into the problems that matter most to the Berkshires. So I hope that you are a regular reader of the Edge. If not, please do come to the Edge website, theberkshireedge.com. The Edge is free to read. It is written by only local writers who know our community well and whom you may know also as your friends and neighbors. So today, in today's webinar, we are very lucky to have a very experienced moderator in Doug Mishkin. Doug is a housing activist. He's also vice chairman of the Egremont Municipal Housing Coalition to Trust. Egremont Municipal Affordable Housing Trust. And he also, in his spare time, is a very good singer-songwriter. So I am going to introduce Doug, and Doug will introduce our panelists. Thank you.
Thank you, Marcy. I'm Doug Mishkin. I'm pleased to serve as the moderator for today's discussion, but once again, I want to assure everyone that when it comes to the housing crisis in Berkshire County, there is nothing moderate about me. This is a program with a point of view. Berkshire County does not have a housing problem. We have a housing crisis. It affects virtually every business, every industry, and directly or indirectly, it affects every resident. Today, we do have a specific focus. Our housing crisis is, among other things, a healthcare crisis. It's a healthcare crisis in at least two respects. Our housing crisis creates a huge challenge in attracting and retaining healthcare providers to serve the residents of Berkshire County. Nurses, physician assistants, dental hygienists, x-ray technicians, as well as physicians, dentists, and mental health professionals. The housing crisis also negatively affects the health of too many Berkshire residents. If you're couch surfing or living in your car, if your home doesn't have adequate heat or otherwise violates state law, or if your rent is simply too high, meaning you're unable to afford food and prescriptions and other life necessaries. Healthcare professionals talk about the social determinants of health, namely those things other than healthcare that can affect one's health. Housing is a huge social determinant of health. Today, I'm hoping we're going to hear stories from people who regularly confront the healthcare aspect of the housing crisis. We do indeed have a panel assembled around the table. We have 6 healthcare professionals and then 2 housing experts. I'm going to introduce each panelist as I bring them into the discussion. In the interest of time, I'm not going to do a reading of each person's impressive credentials. Trust me, they all went to accredited schools. We're going to take about an hour for me to engage them with some questions, and then we will take questions from all of you who are with us today. Submit your questions as you think of them on the Q&A, and we'll get to them by the end of the program. With that, let's start the storytelling. I want to begin with Dr. Eric Bush. Dr. Bush has practiced primary care and internal medicine in Berkshire County for over 30 years. Yes?
Yes.
Eric, thank you for being with us. Tell us in a sentence, what's your practice? Tell people what you do.
So for those of you who don't know me, I have been practicing since 1995. I joined Dr. Andrew Potler. I do primary care adult medicine age 16 till right now 100. And I have a very large practice and have loved and thrived in this community and take care of all aspects of medicine that I possibly can to help people.
So get us started. Question number one. How does the housing crisis affect your practice in terms of having an office with support staff, having other healthcare providers to refer your patients to? Tell us what it means.
It's interesting, Doug, because it's actually evolved a lot over the years. There have been, when I started practice, we had a support staff who were from the area and had lived here forever, and some of them were in Hillsdale, and some of them were in Great Barrington, and as they retired, we found that it became harder and harder to find people to fill the spots, but also who would end up staying in South County. I think, as somebody who has supported Great Barrington and the area around it for 30 years, that we have some really unique aspects to being in South County specifically. And so it really has been a challenge, I have found. And it's not like it changed 5 years ago or 10 years ago. It has slowly evolved to the point where it's really hard to hold on to people. And it's not just support staff in that it is also nurse practitioners. And I worry about the new physicians who are in primary care. I won't necessarily speak for surgeons, just because what physicians earn depends upon what you're doing, what practice you have. So I really do worry. I have seen, for instance, there was a nurse practitioner who worked at our office when I recently have moved to a new practice in Great Barrington Primary Care on Main. But when I was at East Mountain, we had a nurse practitioner who moved to Florida because she felt that the cost of living here was too high and it was hard to maintain her home. This is an example of what I have experienced, and I know I'm not alone in this, on multiple levels with many people. And so it's not like it's the people who earn the least amount that are just having the problem, but it's also people in the middle. And even, again, I worry about our new physicians and will they be able to afford a home like I was able to build 25 years ago.
Sure. So let me ask you about the other dimension of this, namely housing as an issue for your patients.
Yeah.
You've been here a long time. You've cared for several thousands of people.
Many.
How do you see, what have you seen as a housing as a social determinant of the health of your patients?
So I think I'm going to say what the world already knows, which is that we have this real dichotomy. We have those who have and those who haven't. And I take care of both sections of that. There are a number of people whose children can't live here because they can't afford to. I have a number of patients who have struggled to figure out how to pay for expensive medications. There are times when I will do a whole dance to try to speak with a different drug rep to try to get something where we can figure out how to gain access to medicine that otherwise they would not have access to.
And that housing is somehow a factor, the problem of affordability of housing?
Because they have little resources, housing is always your greatest asset if you have it. And so it's a real problem.
Dr. Laura Setti. Laura practices family medicine with Community Health Partners. Laura, thank you for being with us. Tell people who are watching, first, what is Community Health Partners for those who are not familiar?
First, I'll just correct you a little bit. It's community health programs.
Sorry.
That's okay. It's an easy thing to mistake. We just celebrated our 50th anniversary. CHP is a federally qualified health center which provides health care to all people regardless of their ability to pay. We have a sliding scale for people from Massachusetts without insurance. But we are also the only place that people with Mass Health Limited or Health Safety Net can receive primary care. And that's true throughout the state, that federally qualified health centers offer that safety net for primary care for patients. And in particular, I do general family medicine. I take calls still at Fairview Hospital in pediatrics. And so I work closely with the hospital, and I'm the director of immigrant and refugee health for CHP.
Talk to us about how the housing situation affects CHP's ability to serve its patients, staffing up, healthcare providers who are available, not available, support staff.
Well, I think to some degree you're going to hear the same thing from all of us a bit. So one example, I was thinking of examples that we had that are concrete examples. We hired shortly after we were fortunate enough to have a number of Haitian refugees come to our community. We were able to hire a nurse practitioner from Florida, and she was first generation Haitian American. She spoke Creole. She was at a community health center. She was mission driven. She was had a gold stars coming off her head. And she signed a contract and she came up here 3 times, and she could not, over the course of 3 months, find an affordable rental. And she wanted to rent for a year. That's pretty common for health professionals, right? To figure out where she wanted to live. And she felt that she would have to live too far away from where she practiced medicine to make it worth her while. So she withdrew her contract. So that was pretty devastating, because not only were we sorry as a provider team to lose her, but a service to our community was interrupted because of housing. In terms of staff and patients, we see it all the time. We've had patients who leave because they can't afford gas, but also because they just can't afford the housing. I have a staff person who is married, has 2 kids, and lives in a 1-bedroom apartment where she and her husband live in the dining room, but they can afford it. And so they're just afraid to touch it. They don't want to call the landlord with problems. They just don't want to draw any attention to it. And at some point, that's just not a way to continue to live over years and raise your family. And there's no wiggle room for saving and for moving into a starter house, a smaller house. So those are the things that we see. And because, especially in South County, the cost of living is even higher than in other parts of the county, that becomes increasingly difficult. Our patients, though, I think deserve most of the attention, because we can make do. No matter what primary care gets paid relative to surgeons, our patients don't have anywhere near the resources that we have. And for them, we know that the social determinant of health, that is housing, directly affects people's physical health and well-being. When we have lots of 4-bedroom apartments that have 1 entire family unit per bedroom. And so you can have a 4-bedroom unit with 15 or 20 people living in it. One person gets sick, the whole group gets sick. Costs are higher. So it affects our patients on every level. Which then, I will also say, just as a provider, that has a negative impact emotionally. There's some just emotional trauma to all of the care team to try to help every way we can to support people. Well, I can't give you housing, but can I give you food? Can we get you a gas card? We try to do all of these things, but when people have standard, healthy place to live, other things start to fall into place in a more meaningful way. So directly for the patients, which I think is the most important at the end of the day, lack of affordable housing in the county, and in South County in particular, is a problem.
Thank you for all of that.
So well said.
Dr. Ed Weiner practices primary care and internal medicine. Now, I feel like I must say, in the interest of full disclosure, Ed is my primary care doc. which means he qualifies as a GP. That's not a general practitioner. That's glutton for punishment. So, Ed, thank you for being here today.
That's what your wife says.
This is how it goes in the office. Right? A quick word about your own practice.
Well, I've been here 29 years, almost 30 years, and I'm primary care, but I'm also a marriage and family therapist, so everything gets blended. 25 years ago, I stopped seeing new patients when I had a full practice, which is why I'm still in practice at 49 and a half years. And that I've been supported by the health systems in this style of practice has been remarkable. I mean, they've been really wonderful about it. And one of the things that was important to me, joining a practice that had what we call a blind payer system, which my practice in Texas did not have, which meant that everybody deserves the same quality of care. It doesn't matter if they don't have insurance or they have different types of insurance, that you don't look at that, you look at the patient. And that was very important. As far as what we're talking about now, more of what Eric had to say, we had a nurse practitioner from California, Northern California, who signed a contract and couldn't afford to move here, even though she owned a home. I don't know if this is a rumor about one of the cardiologists we had in the last few years who was interested in staying here, but it was more expensive here than where she was living. And then just our own staff, that, you know, if they're not from South County, there's a good chance that they're going to want to get a job closer to there. In our own practice, we've gone from 12 to 13 practitioners, at times to 5 practitioners. And the stress that it's done for the patients and for the practitioners. And you can't just bring in someone and say, okay, you've got a full practice and you need to see a full number of patients. So it's really quite scary. The social determinants of health, we have a lot. It was such a blended community here, which I really love. And it's people who've owned their home for a long time can't afford their taxes. And then they can't afford gas. And then even with medications, like Eric said, you try to get creative. There are certain medicines that retail for $500 a month, like blood thinners. And I have to have the patients get it in Israel, where it's $125 a month. And I have those sites on my computer that the patients see. Really, Maslow said it great, I don't know, it was 75, 80 years ago, that if you don't have shelter and food, don't worry about nirvana. Don't worry about anything else in the standards. You're not going to try to figure out how great life is.
You mentioned the part of your practice that's, did you say family counseling or
Marriage and family therapy. It's being a therapist.
Can you say a word about how housing becomes a stressor in the kinds of relationships that you're helping people through?
Yeah. Well, a lot of the couples I see, most of them are willing to be seen at the same time. And so that gives me an hour with them for both physical and emotional. And you can see, you know, one of the number one issues that any couple has is going to be financial. And so that easily comes up during every visit, and how to support each other and how to play fair, fight fair, do things like that.
All right. Thank you for that. Dr. Pier Boutin practices orthopedic medicine in Great Barrington, and I suppose, additional full disclosure, I have been the beneficiary of her great services. Describe quickly the kind of practice you have, Pierre.
I'm an orthopedic surgeon. I came here almost 25 years ago, but over 10 years ago, I stopped operating. So my practice focuses more on arthritis, non-surgical care, bone health, menopause, general well-being, and I just shifted over the last 10 years.
So, with respect to question number one for the day, how does the housing crisis affect your ability to conduct your own practice? It was conversations that you and I had several years ago where you were telling me about that, and those conversations became the genesis for this program.
Didn't realize I had such an impact.
Tell people.
But a little bit like what Eric said, the problem started gradually over the last 10 years. And we had a harder and harder time getting a medical assistant in the office. And I think probably 50% of the time over the last 10 years, I did not have a medical assistant. And because of that, I couldn't see as many patients. I mean, that's not fair. We are short of doctors. We are short of medical care. But there just wasn't enough help. My office managed because I had an exceptional administrative assistant. And we always connected the dots. We were able to work together and make it work. And then about 2 years ago, she sold her house because she was actually driving from Connecticut to come to my office, but she thought it was getting too far, sold her house, said, hey, I'm just going to rent a house with my husband in Great Barrington, and I'm going to keep working with you until you decide to retire. And she couldn't find anything to rent. Finally, she found a place to rent, but it was much, much too expensive, and she felt that they were spending all their retirement money, what she had made from selling her house. So she ended up moving to Maryland. It killed me. I mean, and then because we couldn't find anybody to replace her here, she's still working for me from Maryland. Because she knows my whole practice and knows how to manage it, and she's holding the pieces together for me. I have to, and you know, like I said, 50% of the time I probably didn't have a medical assistant. We would find somebody, and they came from Pittsfield or Connecticut or New York, and these are usually young mothers, working as medical assistant. And if they found something closer to home, of course they would take that job. I completely understand. But it was just too expensive to live in Great Barrington. And I'm at the point where I would love to have another doctor or nurse practitioner working with me, but I don't think we could have the support staff.
When you and I have talked about the situation that you described, what occurred to me is you managed to come up with a kind of, if you'll excuse the expression, a Band-Aid solution, but only because you'd been here for a long time, you had a long-term relationship with this employee, so you could do that, as opposed to saying to some orthopedist who you might be trying to recruit to the area, come here, you'll have an assistant who lives 4 hours away and can do it all remote. That starting that way doesn't seem to me to be a way to staff up. You managed to put it together, but that was
because she was already trained.
Unique.
But
to
there's
your
no
situation.
you need to be in the office and know how the office works and know what kind of work I do,
right?
To really be able to have that job. But I don't know what I'm going to do if she ever leaves.
Right. Can you say a word about the kind of housing as a social determinant of health as you see it in your practice? How does it affect the health of the people you care for?
Patients have to make a decision between getting a medication versus paying their rent. It is so tight for so many people. And in orthopedics, the medication is not as necessary, so I'm giving them arthritis medication for their joint pain. Well, if you have a choice between having some joint pain versus paying your rent, that's not an option, right? And I have those discussions on a regular basis with our patients. It's not fair.
Thanks for that. Dr. Casey Jones. Casey, welcome. Thank you for being here. You're a dentist. Tell people about your practice and that they should go to your website because it's not the usual dentist stuff on the website.
Maybe you can tell by how I'm dressed. Usual. So yes, thank you for having me. I'm so excited to be here. And full disclosure, I don't know why I feel a little nervous about this. I feel like I have so much to say and I'm not sure I'm going to actually think to say all of it. But we have Inspired Dental Wellness. So Inspired Dental Wellness, I call myself a whole person dentist because your oral health is connected to your overall health, your mental wellness, your sleep wellness. It's all connected and it's never one thing. And so our website tries to meet people where they are, give them some resources, even if they can't come to us, open the conversations. Our mission is to meet people where they are and partner with them on their journey to get as healthy as they want to be.
I just want to point out for all of our viewers, those of us who get nervous going to the dentist, now we have a dentist.
There you go.
I love it. I love it. You're with a lawyer. What could go wrong?
Absolutely true.
Talk to us about, in your practice, the kind of support you need, all of that. How does housing, our situation, affect your ability to do it as you would like to?
Absolutely. Well, first, I'll start with my struggle in that we've talked about how it's hard to find rentals that are affordable. For us, the first time we came to the Berkshires, we couldn't find a place to rent because all of them wanted us to leave for the summer. It was seasonal rentals. And that was not realistic, having 2 young children that were like 1 and 3 at the time. So we were kind of forced to buy a house that time. And then a lot of people here know that I did move away. We went to Wilmington, North Carolina for a while. I didn't mean to do it when the pandemic hit, but we made that decision right before the pandemic hit. In that time, I've been in 40 different practices. So I didn't know that, to me, everything is figure outable, right? I can pivot. I can work without assistance. It's not unique to this area that we're having staffing issues or even housing issues, but it is very pronounced here. So I love the Berkshires. It's my happy place. And I wanted to come back here. And when I was coming back here to purchase the practice I had been an associate in for 6 years, I could not get a loan for a mortgage. So they said that I couldn't guarantee what my income was going to be. I was too risky. It took 3 no's before I got to 1 yes, but it was not realistic to rent, and I wanted to be here. So luckily, I don't take no for an answer very easily. Again, everything is figure outable. But I don't know that most practitioners that haven't been here to know how special this place is would go through all of that to find the ability to do that. And even as I was coming back, thankfully, I had 2 good friends who happened to have space in their home for me to come, leave my family for weeks at a time in order to make the transition here. So that's one piece of it. Then add on top of that we have a waiting list of 50 people or more at all times to get into our practice because there's such a need, just like everything, for care for these local people. And we do our best to get them in, but I am mostly the doctor today. I mentioned Thursday was better because I usually have an associate who is Dr. J. Wise, the previous owner of the practice, is wonderful and thankfully still practicing and usually there on Tuesdays and Thursdays. But ironically, today is a day where he's been out for 2 weeks. Left only me. And, I would love to bring someone else in, but I can't feel good about doing that until I have the support staff to do that. And that has been a struggle in all the years that I've been a part of this practice to find dental assistants. And they're so important. You cannot do what we do without the team that helps us do that. And so if they're not able to find the housing, or I had right after I bought the practice, one of the wonderful assistants left because a practice opened that was 10 minutes from her house and she had a 1-year-old. So I was like, of course, you're not going to drive an hour to see me. I get it. Sucks for me, but good for you. So there's all of those factors that come into play. And if you're a patient who is looking for, again, how do I spend my money? Usually they don't think about oral health, but it is the window to your overall health. And so if your mouth isn't healthy, the rest of you cannot be healthy. It's connected to heart health, diabetes. I'm the only one right now in the area working with sleep wellness, so I make appliances for sleep apnea. Sleep is so important, and if you don't have a consistent place to sleep, you may not actually have sleep disordered breathing, but you're not getting the sleep that you need. So how can you feel resilient? How can you do all the things that you need to do? And it's all connected. It's never one thing.
Boy, it is, and you sure connected it. Well done. Thank you, Casey.
Thank you.
Next, Darlene Rodowitz. Darlene, thank you for being here. Darlene is the president and the CEO of Berkshire Health Systems. And Darlene, by your being with us, you allow us to kind of step back and take a broader view of things. Because your job is to create the systems by which the people around the table and many others can provide the kind of care that we're talking about. So I want to get you to reflect from your perspective as the head of BHS. First, on question number one, the challenge that the housing situation poses for being able to recruit and retain healthcare professionals. What does that look like from where you sit?
I would say, one thing that's I think is correct is that this was a slow brew of getting worse and worse until the pandemic hit. And when the pandemic hit, I think everybody that was within 10 years of retirement did a reflection and decided, is this for me? Can I retire early? Should I move to a different location? Can I change my hours? And suddenly, what was a constant of, like in our health system, maybe having 50 vacancies went from having to 400 to 500 vacancies. That many. Yeah, we're an employer of 4,500, so I speak in big numbers, right? At least for Berkshire County. So that has been our issue. And since the pandemic, we have been investing in pathway programs, and really proud of that work. It's incredibly expensive. We're spending between $5 and $7 million a year, but we've opened up the door for so many people in our community who sat on the sidelines, that single mom who had to pay for rent and food and make sure the kids went off to school, couldn't figure out how to go to school and continue to do that. And so we are paying a full salary, 40 hours a week, while you go to school, and you work 8 to 16 hours for us. You get full benefits, you get paid time off, funding in your pension. So we've taken down the barriers because we needed to increase the number of people who could join the healthcare workforce. Because, these are the jobs, the medical assistants, the nursing assistants, they don't relocate to take that job. They are our friends and our neighbors. So we had to create that capacity to have more people join our workforce. So now, we've spoken off of the medical assistants. They go through a 6-month training program with us, and they get assigned to different offices, and they do some didactic, some in-person training, and then they go into the practice and they do that work with the patients. And every week their scope can grow until they're fully ready, and then they get assigned to an office. We are seeing a particularly acute issue in South County. Most of the medical assistants are Pittsfield and North County. And so the idea of going to a South County practice is for some, it's an impossibility. They would spend their paycheck paying for gas. They may not have a reliable car that can drive that distance. And so, it is a continual cycle, and particularly acute in South County. And because the housing is significantly more in South County than it is in Pittsfield and North County. There are housing issues throughout the county, but more acute, I think, in South County. And so that is a big issue for us. I would say there are other issues around the housing that impacts our patients. We're tracking holistically around our community what are these issues that we have, and we run some retail pharmacies, we do home deliveries, we have the only pharmacy that is a health safety net pharmacy, so if people don't have insurance, we're the ones who fill the scripts for them. And what you'll find is that even with all of that coverage, there's far too many patients that don't have the means to be able to use their meds as prescribed. They stretch them out, they might take half the dose, they let them lapse, and all of those end up in this vicious cycle of being back in the system again because their disease isn't well managed. And so that is the journey we're on. And you can see that, when we look at discrepancies in outcomes, which is how we measure healthcare, is we're measuring it through health outcomes. And so if we think about a diabetic, we have, fewer, let's just, when we look at race and ethnicity, we'll have fewer Black people getting screened for diabetes than white people. That's an access issue. And as a system, we say we're open to all, but what is that barrier? Sometimes it's relationships, sometimes it's hours that somebody works and they can't make it 9 to 5, right? It could be transportation to get there. It could be a trust issue. All of those things come into that. But then when you add on to it someone who is on Medicaid, which is the lower income population, the disparities get even larger. They compound. Right? And so then you start thinking, that disparity isn't because of the Medicaid card, because Medicaid is a wonderful insurance product. It's because of all the social issues that goes around an individual and a family living in the Medicaid income levels. right, that get in the way of providing good care. And it's not the care that's provided, it's the outcomes of that care that is so different. So.
Can you say a word about the use of visiting providers, whether visiting physicians, nurses, X-ray technicians, and how BHS uses them and why they become a part of the program?
Yeah, while we're doing all of this training to fill the gaps, once everyone decided to retire or move on, you have this big discrepancy, and you can't provide the care without having traveling physicians or providers. We call them locums or travelers in the healthcare space. So, they sign a contract. Sometimes it's 1 week a month. Sometimes it's for 6 months. Different discrepancies. So you lose that continuity. We're grateful to have them. Because without them, we would have to divert patients to another health system. They wouldn't be able to get care close to home, and that's never a good thing, right? We all, I think, believe that care close to home is best. So, it is a necessary piece of the puzzle as we're working to develop people. But like a 2-year degree, an associate's degree at BCC for nursing is a 3-year process for most people, right? A rad tech is a 2-year process to get through that. So these aren't things that you can fix overnight. And so it's incredibly important we have those folks. For some, we've had some nurses, especially in the summertime, who sign up to come here and then they choose not to because there isn't anything to rent. So for most of the traveling agencies, they get a stipend for housing. And so if the housing is more than the stipend, they'll look somewhere else. So that has definitely been an issue for us as well.
Wow, it hasn't taken us too long to come up with something of a thread that runs throughout the stories that you've all told,
Sure,
right?
yeah.
It's never mind the people who are never get to the point of applying to come here or receiving an offer because it's unaffordable, but people who actually have the offer in hand and then get down to the nitty-gritty of where am I going to live, and they can't crack that nut and they wind up not coming. We've heard that now several times. I want to shift to our last two members of the panel, our housing experts. So Joey Lindstrom is the executive director of Construct. Jim Harwood is an architect and the president of Community Development Corporation of South Berkshires. Both of you, thanks for being here. Thank you. And what I want to ask each of you to kind of shift the focus a little bit, I want to get your reactions to what you're hearing from others around the table. What are the things that are going on in the world of the affordable housing nonprofits and beyond that to address these situations? And let's get into it, roll up your sleeves a little bit, tell us about that, and then we can push it from there. Joey, you want to get us started?
Sure. Sure, happy to. And first of all, thank you for having me on the panel. Thanks to everyone for all of those delightful remarks and insights. It gives me a lot to respond to, frankly. And I'll say that a lot of what I've heard my fellow panelists talk about is how difficult it is for staff and for patients to live in the Berkshires area. And one of the things that I really caught on were the stories that talked about where somebody else would live instead. Somebody else would move to Arkansas instead, or Maryland instead, or Florida instead. And I start thinking about how are these places different than where we live in Western Massachusetts. And one of the realities that I think is really important to keep in mind is that many of these places have a lot less regulation, and specifically local regulation, as it relates to housing development. Fewer zoning barriers, fewer approvals, fewer required neighborhood meetings, things like that. All of these are part of what's built into a project development's soft costs, the amount of time that it takes to evaluate the approvals, acquire the funding, hire the lawyers, and so forth. And so a lot of what we need to do in order to provide options for people who are getting offers to come and work in this region is to make sure that we just have enough housing for people who want to and need to live and work here, right? And so I do think it's appropriate to take a look at what some of the barriers are to getting shovels in the ground and building housing. And I can tell you, just in a short period of a couple of decades that I've been working on this issue, the amount of cost per unit to build a new affordable housing apartment has gone up more than triple, right? And there are a lot of people innovating. There are a lot of people looking at new creative solutions, but it can't keep up with the rising costs. So to me, I'm really grateful for the advocates and the leaders who are pushing for sensible reforms to get more housing produced. I look at changes to the accessible dwelling unit laws, or some of the work that's being led by Abundant Housing Massachusetts on things like the Legalized Starter Homes campaign and other initiatives to make it easier to build in this area so that there can be more options.
Jim Harwood, want to take a swing at it?
Sure. So I would agree that in the 30 some odd years that I've been an architect, I've watched building costs skyrocket. I think the first project I developed, we built at $58 a square foot. And I am delivering projects, with tremendous subsidies in $400 or $500 a square foot. What I do in my private practice, we're $800, $1,000 a square foot, and so it's a real thing. What we do at CDC South Berkshire to try and address this problem, we kind of have two models. One model that's been very successful for us over the past, 5-7 years is to develop a large apartment building. It's a very tried and true model. It gives you economy of scale. The state brings tremendous, support to that project, and we can make a real difference. And those tend to be rental units. And so let me stop for a second. And I'm hearing in what you guys are saying, there's a problem at two levels and really everywhere in between, right? So it's the people who are just getting by, and it's the people who are in the middle and maybe are making enough money that the various subsidies and all the things that we're talking about, healthcare and housing, aren't available to them. And maybe it's even people who are making much more than that. So we've got established, we're on our third large apartment building, and there's all the great things about that. And I think that those projects, they're able to serve people. Our latest project is 80% of AMI and down to 30% AMI. So that area median income. And so that is, a family of four that's making $90,000 a year at 80%. And, you could do the math to get you down to 30%. It's not a lot of money, and it's an expensive place to live. But that isn't the right solution for everybody and every place. It works well in Lee. It works well in Great Barrington. So we're starting to explore other solutions that we can provide. And actually, full disclosure, a project with the town of Egremont, where you're very influential, is targeting what we think is exactly this problem. And so it is two-family units. And the two-family unit is intended to be purchased by one owner, and that owner can make up to 200% of the area median income. So that has them at around $240,000 for a family of four. And we're subsidizing that building significantly with donations. And big shout out to Egremont, because the community came together with a lot of money to support this project. And then they have to rent that rental unit at 80% AMI. And we're trying to do this with no state money. We're just trying to conventionally fund it. And so our feeling is, housing laws apply, we can't target any one particular group, but somebody like a doctor can afford to buy this house, and somebody like a medical assistant can afford to live in it. And we're starting small, and if it works, we see that this could be a way to work in towns like Egremont and Alfred and Sheffield and all the smaller, more rural areas that an apartment building doesn't make sense for. So we're very hopeful for that project.
I just want to do a little bit more of a plug, because Jim and the CDC and we in the town of Egremont are very proud of this project, and it was Jim's brainchild to come up with the duplex model, which makes the numbers work, makes it affordable. And this has gotten the attention of people at the highest levels of the housing bureaucracy in the state of Massachusetts. There are other towns in the Berkshires that have asked me to come speak to them about how we're doing this. So when you talk to the housing secretary and you say we're talking about 2 duplexes of totaling 4 units, they're usually talking in the thousands of units, but they understood that this was something that could be replicated throughout the state. And part of the reason I like talking about this project is when Jim talked about the AMI levels that we're targeting, those levels were very much influenced by many discussions that I've been privileged to sit in on the ethics committee at Fairview Hospital that Eric chairs, where frequently the discussion is we need more people, housing's one of the problems, and that has informed my own view of the situation here in the Berkshires and the South County in particular. And when it came time to be discussing what will the income qualifiers be for the project, and I said, well, 100% AMI, family of 4, $108,000, and people around the table laughed. And because they know that I'd been saying to them, one of our target markets, if you will, is to be able to house people who work at Fairview Hospital, who serve the town of Egremont. And when I said 100% AMI, they laughed. So why are you laughing? They said, well, you say you want the x-ray technicians and the receptionist and the nurse. And many of these people make more money than that. And that's that hole that Jim was referring to as make not enough to be able to afford the high market rate and too much to be eligible for all kinds of programs that quite appropriately are targeted toward people at lower income levels. So this is one project that is an attempt to address that issue in a small town. I don't want us to delve into statistics, but I think it's helpful for people to understand. In a housing market, we talk about having a healthy vacancy rate, right? And in Berkshire County, my understanding is by all measures, we do not have a healthy vacancy rate. It's far too low. Can you just each say a word about what that means and then how the consequences of it for a community?
A healthy vacancy rate in a community is usually around 8% in rental housing. I think the local markets can vary on that depending on conditions. But the reason it's important to have vacancies is that when renters who are looking for housing don't have choices, landlords can charge whatever they want. And this is how housing becomes so unaffordable so quickly. I can tell you that as someone who recently moved here just a few months ago, even with a pretty decent income for a single individual, there weren't a lot of options for me to look at. And so unlike other markets where I would be in a position where I could potentially negotiate, I could potentially sift through a lot of options and figure out which one was best for me, I sort of had to take what was available. And in a condition of scarcity, the supplier has all of the power, right? And that drives up the costs.
Yeah, and I agree with all that. I would add to it that, also like an employment market, when there's a healthy vacancy rate, things can move and people can move up. And so with housing, we're not one person through our life. We're single, we're a young family, we're a growing family, we're retirees. So you need to be able to navigate through the housing market in all those phases. And if there's the family whose kids have gone off to college, if they're looking to downsize, but they can't effectively do that, then their house doesn't become available to the family that's looking to upsize. So I think if we can just, if you can get a sufficient supply of stock, which helps with negotiation, and I agree about the comments of scarcity, it also just contributes to a system that flows and works as opposed to getting locked up.
Great point.
I want our viewers to know in a few minutes we're going to begin to take questions that have come in the Q&A. and I've got a few more for our housing friends, but I want to invite the rest of you around the table to share comments, questions. Eric.
I would actually add to, just again, to look at the 30-year perspective, and it sounds like you have even longer than I do here.
Oh, no, that 34 years wasn't only here.
Okay. Because what I experienced, which really explains it to me and how I have perceived it again as a physician, is that we've had moments that have affected the region, and I don't mean just Berkshire County, but I mean the country, the region, and all of a sudden you get this influx of people who have so much more money than we do, even if we make good money here. And you know, the 9/11 was an example, and the episode COVID was the huge one recently, and there was the other one around, I think it was 2008. And I know because I met new people. We had new patients, and all of a sudden there's like all this money. I remember the stories of my patient, her son, who bought a house sight unseen at the beginning of COVID because he felt trapped in an apartment in Brooklyn. I mean, in this scenario, I think really highlights one of the dilemmas we have of being in this beautiful place that has a lot of culture that is so close to New York.
And Boston.
But it's like, how do you manage when you're so close to so many people who have so much more money than you can imagine? And all of a sudden, there's an influx. I don't know. That's what you're trying to solve here.
Go ahead.
I mean, the answer is one that Massachusetts is quite good at achieving, which is you tax those people with all of the money, and then you provide some of that tax revenue to Doug's Affordable Housing Trust, and then they make decisions to grant that money to CDC and other organizations to provide some of the solutions. And that actually is the real consideration when we look at especially so many of the properties that would have been rental homes and a housing solution for households that then become instead a de facto hotel room. They're a short-term rental, they're an Airbnb and so forth. And so a lot of the ways that local communities are looking at fees and taxation of short-term rentals as a way to subsidize housing production that can make up for what we've lost in the short-term rental market is the best way to do that, because I don't think we'll ever get to a place where we can restrict people with wealth from buying properties, but there are things that we can do to capitalize on being a somewhat wealthy region. I think the other thing that's really important to keep in mind is there are opportunities when we have public land or when we have buildings that are becoming available, and we can give mission-driven, community-focused nonprofit organizations like CDC or like Construct right of first refusal in acquiring those properties before they hit the open market to be purchased by some of those higher income people who would be moving in and so forth. And that can be a real difference maker in the communities that do it well.
I think,
Darlene.
I just want to, why don't you answer your first and then I'll go next.
there's the proximity to the larger markets gives us another challenge because affordable housing is one part of the housing market, but scarcity, as we've discussed, affects the whole market. And if you're a speculative developer who is going to develop homes that are targeting the middle market maybe or higher, your sheet of plywood costs the same in Berkshire County that it costs in Manhattan or in Boston. But when all those components are put together into a building, it is so much more valuable in Boston or New York City or Westchester or Plymouth. So if I'm a speculative developer, why bother? Right? I'm going to go to the better market. And that's what we're seeing, right? What we're seeing here as our housing stock is we have a bunch of houses with deferred maintenance, very challenging for someone of a limited income to own, somewhat attractive for people who are looking for a second home to come in and make the way they want. And there's no other option. And, again, that two-family model that we're looking at, that's the piece that's missing, that sort of middle market. And it's interesting for me because technically that's not my mission, right? I shouldn't, in a way, be doing that. The only reason I can do that as part of my mission is because of that rental apartment. So the market for us is a little bit broken, and market dynamics, which is really what we've left housing to, isn't working for us.
Darlene?
I just want to, I think what you're speaking to, is, I've heard some people call it the missing middle, right?
They talk about it in healthcare
They
too.
talk about it in healthcare, and I will say, bringing it back to the healthcare issue, you know, when we look at social determinants, the number one issue that we hear from our patients, and, you know, we are an older community than many other counties in Massachusetts, is loneliness. Right? And it's loneliness. And we grow up and we build our homes, even if we're lucky enough to have a home. They often aren't in neighborhoods that have sidewalks and walkable communities. Our children don't come back either because there aren't opportunities or because it's not affordable. And so we age in our home, and then next thing you know, you're kind of trapped in your home. And that's a terrible place for folks to be from an outcomes perspective as well. And so, you know, I think as a health system, we're really curious about, and I love this duplex model concept, that, you know, how do we create senior communities for the middle income folks?
So actually,
So, because we need to get them out of the house and open up the housing stock for the folks that need to get into the workforce housing.
so we're just starting to market these two families, and I've had a very few initial conversations with a growing list of people who are interested. But one of the people I spoke to is retiring, and has their own business. It's somewhat portable. They can bring it here, and they're really interested in the idea that they can retire to this house and have some income that comes with it. And frankly, they were also interested in the mission of it too. They were really intrigued that they could be helping affordable housing in the community that they were moving into. So
If there had been something like that available when my administrative assistant was looking for a place, it would have been great.
maybe for the next one.
We have a question from the chair of Great Barrington's Agricultural Commission. It says, thank you for this important discussion. Would this panel of outstanding experts agree with Dr. Weiner's comment about housing and food as essential for good health? I'm willing to take a guess what the panel might say about that. If so, would you agree with the healthy food goal of Great Barrington's Open Space and Recreation Plan to promote community gardens and residential gardens to help increase local food security? You've got to like a question that's grinding an axe for the advocate. Anybody want to chime in?
Easy one. There's not one of us who don't.
Well, I think it also would go towards the loneliness, right?
Yeah.
That was just raised.
Good.
So
Good. Right.
And enhancing access to the right people so that it goes to people who actually would benefit the most.
Well, and I think, getting, Multicultural Bridge has a large community garden, and then they use that food to give to people who are really struggling with food insecurity. But it's the connection of the full cycle of food. So planting it, growing it, nurturing it, and then letting it nurture you back, but doing that in a way that is communal. So that is also nurturing the community. So it is the whole mind, body, spirit. So yeah, those programs are amazing. And I think, as we struggle in family medicine and my pediatric colleagues with trying to help kids eat diverse whole food diets rather than diets that largely come from boxes, bags, and cans, having community gardens as part of the norm allows us to achieve that.
could I ask the person who asked that question to reach out to CDCSB about our Thornwood property, which is a short-term adult living community, which has actually been supported by BHS. We see it as a place where their locums can come stay, or new doctors till they find a place. But we're very interested in a community garden there. So if there's a synergy, we'd love to talk to you about it.
All right. See, we're doing business here. Here.
I think those gardens are great. A big part of my practice is an anti-inflammatory diet. Like she said, no boxes, no cans. And that really applies to joint pain and inflammation and so many other diseases. But the people that are struggling with the food the most are the older patients that can't really work in a garden. I mean, maybe if their joints were better from before, but there's...
Well, and
they're
that's where I
struggling.
think the community garden works, because even things like Bridge, people raise it collectively and they could give it
That would
to
be
those
great.
members of
I
the
love
community.
that.
Yeah.
That's ideal.
And it kind of it supports our environment, our town. We are about healthy food. Even our restaurants, we try to do that. It's part of our culture here. So to promote that as much as possible and to do that is great.
Well, I can't overlook this chance to do to grind an axe for my good friend, the singer-songwriter Tom Chapin, who did an album years ago where every song is about food, and the title of the album is "Give Peas a Chance." If there are other comments from the group, otherwise I have some more. Oh, something seems to be coming in. I'd like to hear a little discussion about, building new units is one strategy, an important strategy for creating more housing. But I frequently hear it said, we are not going to build our way out of this crisis. Would you guys want to riff on that a little bit? What do you think?
I'm going to, what we do is we build houses, and I'd love to be put out of a job. So we're going to keep building houses. There may be some other ways to get out of this crisis, but I think what we have right now is both a scarcity of housing and a scarcity of affordable housing.
I think the solution really is both. It's not just that we need more housing, we also need to make it so that people can pay for their housing. You do that by expanding a robust job market and making sure that people have good wages, but you also, for many people, especially the lowest income people who are at risk of the greatest and most severe health risks from unstable housing, these are people who usually need help paying for their housing. And so the reduction in vouchers that are available to help people pay for their housing put people at risk of homelessness and put people in a very, very dire situation. So it is true, we need to build more housing, but we also need to do the work to make sure that people can pay for the housing that they have. And so, for example, at Construct, we have a waiting list that's got about 640 households on it. We also currently have 6 rooms that are available at the Windflower Inn on South Niagara Mountain Road. They rent for between $850 and $950 a month. That's a pretty affordable rate. And so you would think, well, if you've got 640 people on your wait list, why do you have empty rooms at that price? And the truth is, people can't afford $850 a month, right? If you're working at Dollar General, or if you're, stocking shelves at a grocery store, if your job is being a cashier, something like that, you can't afford $850 a month. You need to make $2,550. And so, let alone someone who's just making Social Security or disability income. I think there is a really pervasive belief that for lower income people, we have so many programs that that's not really much of our problem, when the fact of the matter is only 1 out of 4 households who are eligible for federal assistance for their housing actually receives it. The other 3 out of 4 households receive nothing. This is different than food security, for example. So if you're eligible for SNAP, you get SNAP. If you're eligible for Medicaid, healthcare, you get Medicaid, right? But for housing, if you're eligible, you sit on a waiting list for 8, 9, 10 years and so forth. And so very, very often, just building something like the Windflower isn't the solution. We also need to find ways to make sure people can actually pay for it. And so it's necessary to have more robust tenant-based subsidies so that people can actually afford the housing that we're building and providing.
Can I add one thing to that, which is just, which I think can be the spiral that we all get into about this. One of the things that I find in both our staff and in my patients is the cost of childcare. So just, I think a plug for universal childcare, because people are putting their childcare expenses on a credit card, and then they can't pay them, and so then they don't have credit, or they have to choose between paying their childcare or paying their rent, and all of this affects their ability to perform their job in the community. And so it really is all tied in together. None of it can be separated.
And sometimes the cost of childcare is equal to what you're going to make. So people will make the decision that they're going to be that stay-at-home parent, which is a great, that's fine. But if it's choosing between the two and you're really not going to come out ahead, I would maybe choose to be with my kids as well. So.
I'm going to go back to the subject that was brought up. When I see anyone under the age of 50, I tell them they're very important to me in the practice, because they're in my 8% of patients that are under the age of 50. So the other thing I'll say to my patients is, because I've taken care of you for 25 years, we've aged together and we have the same health issues. And then, but but then I can think of a dozen patients that I have, or families or couples that I have, that should not be living at home, that can't drive, that I often had to do something with their driver's license, and to not have a car in the Berkshires is pretty awful. But it is such a difficult situation of these patients that you can't get out of their house. And it's very similar to people that have hip replacements quite often, is they can't believe they waited so long to do this, and they would have done it sooner. And this is that so often when you get patients in a more social environment, they thrive. A 92-year-old patient I saw yesterday who just got out of BMC said, "I've never told you, but I have a 70-year-old boyfriend." And he had no idea of my age and still doesn't know. And I said, my mother-in-law had that too. And that was one of the highlights. Yeah.
Gotten a couple more comments from the Q&A. Beth Carlson, the executive director of the Berkshire Community Land Trust, says Berkshire Community Land Trust also works on making homeownership more affordable by providing affordable land access. We hope to develop more housing projects in the future. Our model does address a range of income levels and is for residents. Just adding this information to the conversation. I appreciate that, Beth. This goes on to say, I never hear anyone talk about building a neighborhood of the newest housing model, housing kits developed by Amazon and others. For example, look at the Lake Garfield development, studios and one-bedrooms made with cheap materials and modular designs. New York City used to have SROs. We need a variety of sizes beyond studios and one-bedrooms, but the kits can be combined. Why not go in this direction?
The first thing I would say is I agree we need a variety of housing solutions. I think that both our organizations are providing that, and the Windflower and Thornwood are, if they were in New York City, they'd be called SROs. So
SROs.
Yeah.
Single room occupancy. Single room occupancy. So you could speak to your project. Our project was a former hotel, that was rented to people vacationing here, and now it's 1 and 2 bedroom suites with their own bathrooms and a communal ground floor is communal kitchen, dining room, living rooms, and things like that. So actually, it does provide community, and I was it's also our corporate headquarters. So I was in there yesterday, and a tenant was moving in, and I had the chance to ask him where he came from and what he was doing. And he had relocated from Georgia to be closer to his family, and was taking a job about a mile down the road at a hotel, and was tickled pink. He's like, I've got this room. I've got my own entrance. We've got the landscaping here is beautiful. I can go to my job. There's no tolls between my apartment and my job. And I'm close to my kids for the first time in, 5 years. It's amazing. So I think, we have 16 units there. I wish we had 600 units there. But that's like that helps me get up and do it every day.
I would say there's so much wonderful innovation in these housing models that are being discussed in the comment that you mentioned. There's a lot of innovation around shipping container housing, tiny homes, modular homes. These models have existed for 60 years, the idea of prefabricated or manufactured housing. And there's even examples in California of building assembly lines where a house would be built kind of like a car. It moves in here, you put in the toilet, moves in there, you put in the cupboards, and it's just really, really efficient operations. Many of these models work, but it always depends on the context and it depends on the cost environment. And so at Construct, we're evaluating that option at one of our properties, if it would make sense and so forth. And it'll always come down to factors related to cost, durability, and then also whether or not the site is appropriate. When I was at the Rhode Island Department of Housing just a few years ago, we were working on a big project to put in pallet shelters, which are these very small rooms basically for people who are experiencing homelessness, not that much bigger than this table really. And what we learned is that in Rhode Island, the fire safety regulations were so stringent. What we had to do to get these pallet shelters appropriate from the fire guidelines was so costly that any savings we got from the fact that they were prefabricated was just kind of washed away. And so you always have to evaluate these models in a holistic manner, because while there's lots of great creativity out there, there are other considerations that factor in it.
And I would say climate is another one, because
Climate also, yes.
it's cold here in the winter,
Yeah.
and we need a lot of insulation. And one of the reasons that housing costs have gone up so much in the past 20 years is that we've recognized that houses use a lot of energy, and we're putting all kinds of smart requirements on them to make them energy efficient, but it also makes them expensive to build.
Yep.
There's another comment, but also I am now reliably informed that the comment that I read about the SROs was not from Beth Carlson, so I just want to keep the record clear. Another comment we've received. Thank you for these very important and moving accounts from the panelists. What are some ways for current residents and community supporters to get involved and join in with affordable housing advocacy efforts? How do we keep these conversations going? I don't want anybody to be alarmed, but I have a brief closing sermon that will address some of that. But I'm happy to throw that question to the entire group. Here's somebody who's saying, how do we in the community get involved, join with affordable housing advocacy efforts? I've got my answer to that question, but I'll hold off.
We have these really cool stickers that say, yes, in my backyard. It's a term that many people are familiar with. And one thing that I think is really important in a region like this, where a lot of people love our natural beauty and so forth, is just we need more housing everywhere, and everywhere has to include right here, wherever I'm standing, wherever you're standing, where you're sitting, everywhere, because there's so many people throughout our communities that believe in affordable housing, but not here. This isn't the right place for it. It makes more sense over there, over here, and so forth. And so what we really need is a culture of people who aren't coming up with reasons not to build, but coming up with reasons how we can make it work, and working collaboratively with the people like CDC or Construct who are proposing the projects to figure out how to make it work. Because ultimately what we need is more housing, and we rely on the voices of neighbors and community members to move those projects forward.
Yeah, and I think, interestingly, literally, yes, in your backyard, because now there's an ADU law that says that you could put a house in your backyard and they can't stop you. So if everybody did that, we would have twice as many houses in the Berkshires.
Great point.
So
And-
question about that though,
Yeah.
like what is if some of that is just used for Airbnbs, which I think everybody appreciates the value of Airbnbs to a community to bring people in, but people come to this community for a variety of reasons. I mean, people are from this community and serve us. That's part of what we're all talking about, to help serve healthcare. But they also come to visit. But if we can't house our restaurant workers and the staff that work at Jacob's Pillow and Tanglewood and all of the other Mehewi, all the other reasons that people come here, then we're kind of stuck, right? So it seems like, I mean, I know you guys are working all this, but it does seem like there's some balance in that.
Yeah, so again, just like we were talking about a healthy vacancy rate, I think all of us probably remember in our childhood going someplace like the Cape and staying for a week in a house that was rented, right? So the short-term rental is age old, right? What's the problem now is we've got a system that's out of whack. So if we can eliminate the scarcity, some of that will take care of itself. Until we get there, so the state's made it very easy for you to put a unit in your backyard. The state's also willing to lend you money to do that if you're willing to accept certain restrictions on what happens in that unit. So creating a right for everyone, and then saying, if you're going to use that to support affordable housing or restrict so that it's not short-term rental, we'll give you an attractive loan rate. So I think that's a great step. We haven't really seen it gain traction here yet in the Berkshires. I think part of that reason is what I'm referring to is the person who does that in Plymouth is going to make a lot more money with that, and the house is going to cost the same. So, but we're moving in the right direction. The other thing I would say, yes, in my backyard, literally, but so some people have the means to donate and directly fund affordable housing, and so in our organization, we collected $2 million of donations over a 5-year period and delivered $40 million of economic development in the county. That $40 million was 100 units of housing. It's like a real success story. Not everybody has those means. If you could show up to a meeting, as Joey was just referring to, and say, yes, in my backyard. This is affordable housing. It might be a little scary, but it's not really. Don't worry about it. We can have this here. And we need people to show up in your town at that meeting and say it's okay, because the people who tend to show up at those meetings are the ones who are most against it.
You know, I should piggyback on that comment a little bit, because I think a lot of the time in the conversation about the affordability crisis in the Berkshires, a lot of people think of wealthy second homeowners or wealthy people who move here from other cities as sort of the enemy who crowd out other people who grew up here, who want to work here and so forth. But the truth is, many of the people who have means in this region understand the affordability crisis and do invest considerably in organizations like ours. And I've been really quite impressed by the generosity of people in this community in the 4 months I've been here, and the philanthropy that really exists as a culture. And when I tell other housers throughout the country who I'm in touch with about the level of donations and contributions and foundation support, people are quite jealous. And so I will say that I think there is a lot of civic duty and focus on impact from the people who bring wealth to this community. And I think that's been really impressive as well.
And I think community is a recurring theme. You guys are a community of doctors. This is a community I chose to move to. I could have moved to a lot of other communities, but it was because of all these things, the natural resources, the cultural resources, the food, the towns. So I think as a community, we can solve this problem.
I've got my eye on the clock. We're going to wrap up in a few minutes, and I do indeed have a few closing remarks, but I want to make sure that any of you who has any other questions or comments around the table to make gets to do that.
I have a question for the two of you. Can you see progress? Do you feel like we're getting better and it's going to be better in 5-10 years? Or are we just barely, are we going to catch up?
So
we have two different perspectives. You just moved here. I moved here 18 years ago. So go ahead and then.
Well, I'll say I don't really answer that question locally, because I don't think of the housing crisis as something that's being experienced here in Berkshire County. It is being experienced in unique and idiosyncratic ways here, but it's being experienced everywhere. It's here, our problem might be affordability. If you go to West Virginia, the problem might be housing quality, right? There are different facets of the problem that are more profound everywhere. But I like to remind people that it wasn't that long ago that there was basically no homelessness in America, right? In 1974, we still had people returning from incarceration, working minimum wage, dealing with disabilities, fleeing domestic violence, and they mostly all had places to live. And that's because in 1974, we had a surplus of affordable and available homes for extremely low-income people, and now we have a deficit of 7 million homes. That is the difference. It's how many homes we have and so forth, right? And so when people think about this problem as something that is impossible to solve, I like to remind them it wasn't that long ago that we had solved this problem. And so we have to keep being creative. We have to keep working to build more resources and expand the political will to develop the real changes that move the needle. But I definitely know that just in the 4 months I'm here, when I see people move out of their car and into our transitional housing facility and then get a job and then move into a new apartment, and just the way getting keys to their own apartment impacts their lives. Or when we have someone who has been living in the same house for 60 years and it's in bad condition and the heat doesn't work, and we put this woman in a motel for a week using some of our warm up the winter funds, and then a podiatrist tells us if you hadn't done that she probably would have lost some toes, right? And so I see that the work that we're doing is making a difference. And so I don't know if we'll solve it in my lifetime. I know we won't solve it tomorrow, but the way I always think of this is it won't be solved right away, but we can make progress every single day. And that's what we really need to remain focused on.
And so I would say just locally, because that's where I've been focused on this. I have my experiences from growing up in New York City, but I think that in the past, since COVID, there's been a really marked shift in how affordable housing is perceived. There's an awareness that, I think there was a bias that people who needed affordable housing were probably lazy and didn't have a job, right? But I think there's a recognition now that that is really furthest from the truth. And so, I don't know, 7 or 8 years ago, maybe 10, because everything that was 7 years ago was probably 10 years ago. We had a project rejected in a town here in the Berkshires, and it was a total NIMBYism. And this past year, we had presented a similar project in the town of Lee, and it just, everybody was behind it. Not everybody, but almost everybody was behind it. And so there's a real shift that way. And then the state, I've really seen just doubling down on their commitment to solve this problem. And even to recognize that in the rural end of the state, it's a slightly different problem. We're not this. So I don't see solving this problem maybe in my lifetime, but I do see getting traction. I do feel like we're starting to get some forward momentum. And I would, if you think something's hopeless, you don't try. I think, again, the community, there's a way we can make a difference. And let's all keep at it.
So with that, let's segue to my taking the prerogative of the moderator position to preach a brief closing sermon. First, I want to thank all of you, or each and every one of you, for being with us today. And not just for your time and your insights, although that, of course, is important. But each one of you, in my view, has stepped up to the plate to play a part in helping to educate all of us about the seriousness of the housing crisis for healthcare. One member of the panel, who shall remain nameless, said to me a few weeks ago, "You don't need me, the others will say what I would say." And my response was, we need everybody saying these things, telling these stories. I have my own stories. The x-ray technician at Fairview who said to me one day, "Well, I live in Florida, my wife and I would love to live here. We took our kid over to the elementary school in Sheffield, but we can't find an affordable place." And then the phone call I got, and I get these calls frequently because I am affiliated with a law firm that represents tenants in housing court. The woman who called me to say, "I'm losing my housing. I was married, then I got divorced. I lost my house in the divorce. I've been renting in a home for many years, and now that owner is going to sell, and I have no place to go." And I'll never forget, she said to me, "Don't you people want therapists in your schools?" That voice haunts me. I think the most important question to ask at the end of a program like this is, what can I do? If we're going to solve this problem, it's not going to be because somebody else is going to do it. We are going to do it. I have 3 suggestions. First, donate. Some people can donate money. Some people can donate time. Whatever it is you can donate, it's about giving time and money to the organizations who are addressing this crisis here in Berkshire County. You've heard from 2 of them today, from CDC of South Berkshire and from Construct. There are other organizations as well, like Habitat, Hearthway, Upside 413. Second, as a practical matter, if you have residential property that you rent, think about whether you could rent that property as an affordable rental. I'll grind my Egremont axe. In Egremont, we give a break on real estate taxes to owners who rent affordably. Lastly, become an advocate. Every one of us become an advocate. If you're a healthcare provider, please be a vocal public advocate for affordable housing. Tell your stories the way you've heard stories told today. And as was mentioned earlier, speak up. Speak up at your town meeting, at the select board, the planning board, the housing trust, the zoning board. The voices of the healthcare community get listened to. You have a moral authority that goes along with what you do. And then I say to all of us, to all residents of Berkshire County, I think all of us need to view every issue that comes through our town through the lens of, is what we're doing going to help or exacerbate the housing crisis? I think all of us should be collecting stories, and it's something we can do on a daily basis. Ask the person behind the counter in the store, where do you live? Ask the person waiting on the table. Ask the staff at BMC or Fairview. Let them tell you their stories, because all of us become better advocates when we can reduce this crisis to the stories of real people who live here or who want to live here. Solving the housing crisis is not going to solve all of the problems of healthcare in Berkshire County, but no problem in Berkshire County, housing, employment, our schools, no problem can be addressed without addressing the housing crisis. Pierre asked a moment ago of our housing experts, what do you think? Are we going to solve this crisis? When I hear questions like that, I think about my personal hero, the great folk singer Pete Seeger. Are we going to make it? And his answer has become my answer to these questions, which is, I think it's 50-50. And what that means is what each one of us does or does not do matters. Again, thank you to all of you around the table. Thanks to all of you watching on Zoom. And finally, thank you to the Berkshire Edge and to its extraordinary and apparently tireless publisher, Marcy Setlow, for this kind of enlightened approach to covering this critical issue in our community. Thanks, everyone.